Dear students, welcome back. Good evening. So, the purpose of today's class is have a flashback recall of the previous 5-year questions which appeared in the exam FMGE because your date has already arrived, and now the final, you will be gearing up towards, it will be kind of a final revision. In that process, it is always advisable to go through the previous year questions, especially the last 5 years, and work upon the topics which you find are important, will be repeated. As I see, Keshav, Anjali, Dr. Kaushal, Suman, Atul, Mohammad Hafiz, good evening to you all, and let us begin now. As you understand, we will be taking care of the previous year questions. Not all of them as such won't be possible, but some of the topics which we believe will be repeated in the upcoming exam. Very recently you got the date of the exam also. So, this is the very first question. We are starting with histology, and it is asking us to identify the arrow mark structure. December 21 FMGE. As you notice, your eyes should be actually able to identify the structure as soon as possible, but then as you go through the choices, you will notice the names: interarytenoid, something to do with the larynx muscle, then longitudinal muscle of the esophagus, or they are mentioning circular muscle of esophagus, gut tube basically, and trachealis, a muscle of the trachea. So, some muscles related to gut tube and respiratory tube, and as we identify the structure, immediately you will be able to see that we are actually looking at the C-shaped cartilage of the trachea. So, this is the region where we can actually demarcate the C-shaped cartilage of the trachea. This is the lumen of the trachea. Now, once we identify this is trachea, which is in trachea, which is a respiratory tube, you will having C-shaped cartilages which are hyaline cartilages, about 15 to 20 to maintain the patency of the tube, because we are breathing through the tube. So, you need some rigidity to the tube, but there is a deficiency on the posterior aspect, and that is where the arrow is being shown here. That deficiency they will be asking. Here is actually a muscle of trachea. So, you got your answer, and your answer would be the trachealis muscle. Now, once you say our answer is trachealis muscle, we can have some more details of this diagram. We also want to talk about the muscles of the esophagus here, the gut tube. So, as I go through the chat, thoughtful is being very thoughtful and mentioning, पढ़ लो यार भाई, गुड इवनिंग करे जा रहे हो पर पढ़ने वाले हैं सारे, आप सारे पढ़ने वाले ही हैं, आपने आंसर ऑलरेडी दिया है, डी आपने ऑलरेडी बता दिया है. सो इन द लास्ट रिवीजन सेशन you should be practicing as many MCQs as possible and working upon the topics. As we see, this is looking at the two tubes from posterior view. So, what are these two tubes we are talking about? As you will notice, because we are looking from posterior view, we will find that there is one tube which is esophagus and a continuation of the pharynx. Pharynx becomes esophagus. So, this is the esophagus, and it is posterior in relation. In front of esophagus, you will have the trachea. So, you can also notice the trachea here. This is the trachea. Trachea is identified by the thing that it is having a lumen, and it will have this 15 to 20 C-shaped cartilages, but which are anteriorly present. As you can see, they are ending posteriorly. So, these are the C-shaped cartilages, but there is a deficiency on the posterior side, and that deficiency, as we mentioned, is filled by a muscle, and that muscle is called as trachealis muscle. So, we are talking about that area. So, trachea is anterior, esophagus is posterior. We are taking a section histology section at this level. What else you can see is the thyroid gland, which is actually in front of the trachea, ring number 2, 3, 4, and behind the thyroid gland you will have the 4 parathyroid glands. So 4 parathyroid glands, they are basically lying on the posterior aspect of the thyroid gland. Thyroid gland is most anterior. If you remove it, then you'll have the trachea. If you remove the trachea, then you'll have the esophagus. And as you take this section, you will notice, for the purpose of histology, this is the diagram. So one is, as you will notice, low magnification view, but then we have magnified it higher, and this is the lumen of the trachea. Again, I'll mark the cartilage. As you are marking the cartilage, this is the C-shaped cartilage here, and which is lying anterior and lateral to the trachea. But then you will have to discuss some more details, because when you discuss a topic, there will be a lot of other details which the examiner will be interested in asking. Say, for example, if you are looking at the epithelium, tell me what is the epithelium of trachea. Trachea will be lined by respiratory epithelium. And what is respiratory epithelium type? It will be the pseudo-stratified columnar epithelium with goblet cells. So as we talk about the respiratory epithelium, it will be pseudo-stratified ciliated. It is also with cilia. Pseudo-stratified ciliated columnar epithelium with goblet cells. That is the epithelium. And you will notice that this is the lumen of the trachea, C-shaped cartilage anterolateral, and the muscle which we were talking about, the trachealis, will be filling this gap here. As you will notice, this gap will be filled by trachealis. Let us magnify this diagram also. And behind that is esophagus. Esophagus is identified again by having a lumen. Food will be passing through that lumen, and it is collapsed. When food goes, it will dilate, otherwise it will be collapsed lumen. And what will be the epithelium of the esophagus? What will be the muscles outside that? All we can discuss. As we proceed further, you will notice that we have magnified the diagram now, and it will be evident that this epithelium we were talking about is the pseudo-stratified ciliated columnar epithelium, and this is the muscle we are talking about, trachealis muscle. So smooth muscle basically, and the smooth muscle is lying here. So we have magnified this part of the diagram, and that is the trachealis muscle. Tell me, this trachealis muscle is a smooth muscle. In asthma, what will be happening? In asthma, there is hyper-responsive tracheobronchial tree, and there will be a spasm of the tracheobronchial tree, difficulty breathing. So in asthma, when there is hyper-responsiveness of trachea and bronchus, and the smooth muscles become hyper-responsive, the trachealis will be contracting. As trachealis will be contracting, and smooth muscles also around the trachea will be contracting, the lumen will be reduced. Which neurotransmitter is working? That is acetylcholine, and that is a problem. In asthma, there is more of acetylcholine. There is overactive parasympathetic system, and this muscle is undergoing contraction. Not only that, because you have asthma, there is more of acetylcholine. You will also notice the glands which are there in the trachea. They are hyper-responsive, and they are giving a lot of secretion. Those secretions will fill up the tracheobronchial tree. So not only the lumen is reduced, but it is filled with secretion. That is asthma. So how do you treat it? There will be several drugs given, but one of the drug which you give is called as the ipratropium bromide. So can you tell me what is the function of ipratropium bromide in the chat? Let me see. Sir, आप एनाटॉमी पढ़ा रहे हो या फार्माकोलॉजी पढ़ा रहे हो? देखो, हर चीज़ जुड़ी हुई है. अगर आप ये कहोगे एनाटॉमी अलग है, फार्माकोलॉजी अलग है, फिजियोलॉजी अलग है, ऐसा कुछ नहीं होता. Everything is interrelated, and that is the beauty of medicine. So tell me, what is the function of ipratropium bromide here in asthma patient? What does it do? M3 blocker, muscarinic blocker. So you can understand that ipratropine bromide is anticholinergic, and if it is anticholinergic, if it is working against the cholinergic system, what it will do? It will reduce the secretion, dry up the secretion and reduce the contraction of trachealis muscle. That was your question. So trachealis muscle was under severe contraction due to asthma, hyperresponsive, more of parasympathetic activity, and you are trying to block it. You can give sprays. Now this was about the trachealis muscle. What about the esophagus? As you see, this is the other tube we are talking about, and as we focus upon this tube, you see we have magnified this area now. That is trachea, this is esophagus, collapsed lumen of esophagus. Focus here and you will find this epithelium. So what is the epithelium of the esophagus? Esophagus is lined by stratified squamous epithelium, non-keratinized. These are all MCQs and they are repetitively asked MCQs. So you can write non-keratinized stratified squamous epithelium, and that is epithelium you will find in the esophagus, non-keratinized stratified squamous epithelium. Now if that is the epithelium, this is mucosa. What is under mucosa? Under mucosa we have the submucosa, and as you talk about the submucosa, it is a special feature of esophagus that in the submucosa you will have glands. See, esophagus is a gut tube and they do not have glands in the submucosa. Usually the glands will be in the mucosa, not the submucosa, but esophagus and duodenum, they have glands in the submucosa, and these glands which are there in esophagus may not have a name, but the gland, submucosal gland in duodenum, they have a name and they are called as Brunner's gland. So a question can come on, not can come, it already had arrived, it was there. There is a question in FMGE itself. Brunner gland. What is the Brunner gland? It is submucosal gland. Where? In the proximal duodenum. So it will be giving some secretions. That is a totally different topic, but we are revising the last 5 years MCQs, and that is what we are doing here. Now in the esophagus, because it is a gut tube, it will have some muscles, smooth muscles, and as you locate those smooth muscles, you can find yourself here. This is going to be the inner circular layer of smooth muscle. Gut tube has inner circular layer and outer. Outer there will be a longitudinal muscle. We can choose some other color, maybe green itself. So this is a cut section of the smooth muscles which are outer longitudinal. If you remember, this was in your question. Let us go back to the question now. In the question you had inner circular outer longitudinal muscle of esophagus as well, along with the muscle trachealis. So as you go back to your question, this is your question and you already have answered the question, but the point is, see, it's very important for you to understand when you practice the MCQs, not only the answer is important, not only the answer is important, but also the other choices are important. You must explore the other options, like interarytenoid will be a muscle between arytenoid cartilage of the larynx. Larynx has arytenoid cartilage, and between the two arytenoid cartilages, right and left arytenoid cartilages, you will have a muscle, interarytenoid muscle, which we can talk about later also. Then longitudinal muscle of esophagus, we have seen a section, and the circular muscle of esophagus, inner circular outer longitudinal. So you must know the details of not only the answer but also other option, because examiner will keep changing the options or maybe the stem of the question, maybe the diagram itself. So you should work upon not only the question but around the question. The topic is more important. Maybe this question will never come again. Topic will keep coming again and again. So I am hopeful this will help you, and we have done some 10 to 12 MCQs by this time, though it is one MCQ, but I have taken care of around 10 to 12 MCQs. That is how I teach. That is how you should also learn. Sir, by what mechanism the secretions from the goblet cell travel up towards the lumen? as goblet cells are having no ducts, goblet cell, the secretions are directly poured into the lumen. You will find this epithelium is having goblet cell, and the secretion of the goblet cell will be directly poured into the lumen. You don't need any duct here. So what is the difference between serosa and adventitia? See, esophagus is mostly lined by connective tissue adventitia. Until you enter towards the abdomen and become stomach, esophagus will become stomach, but then stomach is covered by peritoneum. So little bit of esophagus will be covered by peritoneum. That peritoneum which covers the esophagus from outside is serosa. Let me show that diagrammatically. Say this is the, let me draw it here itself. Say this is the esophagus here, this is the esophagus, and then it becomes the stomach. But then we understand that the stomach is in the abdomen region below diaphragm, and if it is below diaphragm, say this is the diaphragm, this lower part of the esophagus, the outermost covering will be peritoneum. And what is the outermost covering before that? The outermost covering before that is connective tissue adventitia. So the outermost covering of the esophagus is connective tissue adventitia most of the length until you come into the abdomen, and that part of the esophagus will be lined by peritoneum. So you say peritoneal serosa. That is peritoneal serosa. So serosa is simple squamous epithelium of the peritoneum. But connective tissue adventitia is basically a lot of collagen fibers, some elastic fibers, and plus blood vessels. In the connective tissue adventitia, you will have blood vessels distributed to supply the esophagus basically. So that is the difference you asked me, so I mentioned. Okay, it will be better that whatever topics I thought should be discussed, we focus upon that because we have limited time. So what is the next question? As I already have mentioned, the questions which we are taking are repeat questions like FMGE December 2021. But be careful, I will take only those questions which are relevant for the next coming exam, and plus they have been repetitively asked, plus these questions. When we do one question, we are taking care of almost 10 more. So one MCQ equals to 10 because we discuss around that topic. So what exactly is this question? It is, you understand these days they give you histology slides, identify this, what is the function of that cell and all that. So what is this question asking? The marked cell secrete which hormone? First of all, we have to find out that what is this diagram about and what are the options. Always go through the options quickly. So thyroxine, okay, this may be something to do with the thyroid gland, or calcitonin, maybe it is parafollicular C cells, or adrenaline, is it a adrenal gland, or the prolactin, are we looking at pituitary gland? So what do you think? As I go through the options, you already have answered, very good, calcitonin. So that is the beauty of practicing previous year questions. You will always know the answer, but be aware, this question may not come again. So not only you have to remember the answer, you have to explore the other options also, and you have to think that what could be the next question based upon this topic. So that is what we are going to do. This is parafollicular C cells, you are very correct, fantastic. And you know, another word of wisdom, that for FMGE, you just have to clear the barrier of scoring 50%, and you must think before the exam, during the preparation only, that I have to clear this exam. There is no other way. You should be very sharp focused. You may start with 3 hours, 4 hours per day. Increase this duration of 3-4 hours per day of practicing previous year questions to 5 hours, 6 hours. As the exam approaches, 10 hours per day, 12 hours per day. As I remember, in our PG entrance exam, we used to study almost 14 hours per day, which may appear inhuman, that how is it possible? Is that even possible? But we have been through that. It is possible. You have to gradually build up. It's a marathon, and marathon should be continuously run, and you should be slow, but persistently you should be doing. So maybe your exam is on in the month of July, the last week of July. Before that, you should reach this maximum potential of 10 to 14 hours per day. And I don't think that it is going to be very difficult for you to clear the exam. You will definitely clear this exam. Only thing is you have to be persistent. You have to practice a lot of MCQs, maybe some 100 MCQs per day. But if you do it this way, you cannot practice 100 MCQs. So at least 10 MCQs and taking care of 100 MCQs. One MCQ you should attempt and take care of 10 around that. Anyhow, how do you do that? That is also important to learn, and that's what we teach you. So what do you think? You already have answered. I know you people are well prepared. So you already gave the answer. You gave the answer as calcitonin. So what are we looking at? You see, this is a nucleus here. Let me mark the nucleus. See, this is a nucleus here. This is a nucleus here. This is a nucleus here. This is a thyroid follicle. Inside that you have thyroglobulin, or the colloid, which will be thyroglobulin, which will form thyroxine hormone. So thyroxine hormone is given by thyroid follicle, one of the follicle you can see here. Now you can see another follicle. This will be thyroxine inside that. Can you see the difference in the nucleus? These nuclei are different. At one place you find that thyroid follicles are lined by, cells having round spherical nucleus, which is feature of cuboidal epithelium. Whereas at other place you find, you see here, this one, let me change the color, and you will find, look at these nuclei, they are flat. Now, so sometime you may have a thyroid follicle where the cells are such that they have flat nucleus. Now if they have flat nucleus, what do you call it as? It is squamous. The point is, this question has already come actually many times. The point here is, the examiner may be interested in asking, what is thyroid follicle lined by? Your first answer should be, thyroid follicle is almost always lined by cuboidal epithelium, where height of the cell is equal to breadth of the cell. Central spherical nucleus, height of the cell equal to breadth of the cell, and you cannot see the cell as such, but you can see the nucleus. Let me rub this off and you can see for yourself, these all nuclei are spherical nuclei. Now as you compare this with the other nuclei, notice here, these nuclei are not spherical, they are becoming flat. So why they are becoming flat? Normal follicle, moderate secretion, it will be cuboidal. If the follicle is totally filled with colloid, cell don't need to secrete anything, resting cell. So when the cell is resting, you will find that it becomes squamous. So can the thyroid follicle be lined by squamous epithelium? Yes, thyroid follicles can be lined by squamous epithelium. Another question comes, it will be asking you, actively secreting thyroid follicles are lined by. What is your answer? A question came, it was asking, actively secreting thyroid follicles are lined by. What is your answer? Prolactin is secreted by anterior pituitary. How we approach histology question, that is what I am teaching you. This is how you approach histology questions. Adenine secreted by adrenal medulla, correct? Tell me the answer to my question. My question to you is, actively secreting thyroid follicles are lined by? Columnar, correct. Swet Ketu Patel, columnar, correct. So let me put some lines. You have to understand this. Maybe this becomes a little bit more for you, but that is how you should remember. See, there are several questions. Question number one. Question number one is thyroid follicles are lined by. Your answer is simple cuboidal epithelium, no problem. But there is another question they will ask you. Actively secreting thyroid follicles lined by. Here you change your answer to simple columnar. Now, why this cuboidal becomes columnar? How do you identify cuboidal from columnar? If you are telling that it is cuboidal, then you will have central spherical nucleus, height equal to breadth of the cell, normal thyroid follicle. But when there is actively secreting thyroid follicle, change your answer to columnar. Columnar identified by oval basal nucleus, oval basal nucleus. Basal, when you say, it means you will have lot of cytoplasm above the nucleus. This is cytoplasm. So here there is less of cytoplasm above the nucleus. Cytoplasm will take eosin, and what the nucleus will take? Nucleus will actually take the hematoxylin. This is hematoxylin, blue color hematoxylin and red color eosin. So how do you identify the cuboidal with columnar? In cuboidal, central spherical nucleus, less of cytoplasm above the nucleus. In columnar, oval basal nucleus, more of cytoplasm above the nucleus. This is actively secreting follicle and this is normal thyroid follicle. But sometimes thyroid follicle can be simple squamous also. How will you identify simple squamous? Simple squamous epithelium will be identified by the fact that it will have a flat or globular nucleus, and the cytoplasm which is above the nucleus will be very thin rim of. So you mean to say thyroid follicle can have all the three epithelia? Yes. Which is the best answer? Cuboidal. And what is the answer if it is resting follicle? Resting thyroid follicle, if question comes, simple squamous. And what is the answer if actively secreting thyroid follicle? Columnar. Maybe you have read it or maybe you have not read it, but these are the questions which you must expect from the examiner. Let us go back to this diagram. In this diagram, as you can notice, we are looking at several thyroid follicles. You see, this is one thyroid follicle, this is another thyroid follicle, this is another thyroid follicle, this is another thyroid follicle. In between the follicles, parafollicular C cells. These are parafollicular C cells. Your question is on parafollicular C cells. Why it is called parafollicular? Because between the follicles. And why it is called C cell? C cell is clear cell. And what is clear cell? Why it is called clear cell? It is called clear cell because it takes less of staining, hematoxylin and eosin. So what you look at is nuclei of parafollicular cells here. I'll rub it off so that you can see them again. These are parafollicular C cells. They are called clear cells because they appear clear. They take less of stain, less of eosin, hematoxylin. And what do? They are giving us thyrocalcitonin. So they give us a hormone which you can mention maybe here, thyrocalcitonin. What is the purpose of thyrocalcitonin? Thyrocalcitonin is going to antagonize parathormone. And what is the function of parathormone? Calcium metabolism, increase the level of calcium in blood, that is parathormone. So if parathormone is to increase the blood calcium and the thyrocalcitonin is antagonizing it, what does it do? Thyrocalcitonin is antagonizing parathormone, so it will reduce the blood calcium. And how will you reduce the blood calcium? It is taking the blood calcium and depositing in the bone. In osteoid formation, you deposit mineralization. So take the calcium from the blood and give it to the bone. So calcium metabolism. Another question comes, parafollicular C cells are embryologically derived from? And your answer is parafollicular C cells are embryologically derived from ultimate branchial body. Now, what is this ultimate branchial body? As you talk about the ultimate branchial body, it is basically a remnant of pharyngeal pouch 5, but attaching to pharyngeal pouch 4 on the dorsal side. I'll repeat again. Where is this parafollicular C cells derived from? Ultimate branchial body. And what is ultimate branchial body? It is a remnant of pharyngeal pouch 5 attaching to pharyngeal pouch 4 on the dorsal side. But again, you have not answered the question. Question is asking, parafollicular C cells are embryologically derived from. You have told the location, but you have not told the source of the cell. And I think some of you must have answered. Tell me. Have you heard about neural crest cells? So, they are derived from neural crest cells. Neural crest cells will be migrating to ultimate branchial body and form the parafollicular C cells. So, if a question comes, parafollicular C cells are derived from, your answer is neural crest cell. And if neural crest cell is not in the option, then your answer is ultimate branchial body. And if ultimate branchial body is not in the option, then your answer is remnant of fifth pharyngeal pouch. And if that is not in the option, then dorsal side of pharyngeal pouch number 4. So, you should be ready with the backup answer. And I will advise you, so this class is actually very short duration and I cannot teach you everything, but advisable is that on YouTube from PrepLadder or from myself itself, you will see previous year questions of FMGE are already recorded and uploaded. So, if possible, go through them and you will have more details. Your job is practice as many MCQs as possible. That is the only advice I give to my students. Maybe you are preparing for your FMGE or maybe you are preparing for your PG entrance. There is only one way, the best way. Practice as many MCQs as possible. Sir, inferior parathyroid gland also from fifth pharyngeal pouch? No. Inferior parathyroid, if you ask, just remember this mnemonic. If you have ever attended the class, you might be knowing also. The mnemonic is PP3 tip. PP3 tip. Now, what is this PP3 tip? Pharyngeal pouch 3. Pharyngeal pouch 3 will give us thymus and inferior parathyroid. We will be discussing in the class also, but pharyngeal pouch 3 will be giving thymus and inferior parathyroid. So, if you are asking me that inferior parathyroid is from which pouch? Pharyngeal pouch 3, and they will be missing in DiGeorge syndrome. In DiGeorge syndrome, which is a problem of neural crest cell, you will find that pharyngeal pouch 3 is missing. So, thymus is missing and inferior parathyroid is missing. So, I hope I have answered. PP3 tip, fantastic, good. Okay. So, let us not spend too much time on this particular topic. Let us move on to the next topic. And you see, these are all repeat questions and repeated several times. So, tell me what is the answer to this particular question. It is asking us skin receptor, which is responsible for detecting rapid vibration. So, that means there are two types of vibrations. Normally, examiner will be asking either rapid or it will be slow frequency or high frequency. Rapid means high frequency, but question can be on slow frequency also. So, what do you think is your answer? As you go through the choices, always go through the choices. There are all some receptors in the skin receptors. So, if they are skin receptors, fine, but what is the answer? What do you think is the answer? You already have answered B, fantastic. So, it is understood that yes, deep pressure and vibration. So, I can appreciate that you already have been through previous year question, that is how you are able to answer. But again, when you take care of one MCQ, you should take care of 10 more MCQs. And how do you do that? Let me show you. Of course, you are correct. Your answer is definitely the Pacinian corpuscle. Just remember P for P. What is P for P? Pacinian for pressure. Now, if you remember P for P, not only Pacinian is for pressure, it is also for vibration. pressure and vibration, but that vibration also if it is rapid vibration. Now, if Pacinian Pacinian for pressure and also vibration, and vibration that is rapid vibration, which neural column carries that? What I do is I go through last 15-year questions and try to relate everything with each other, connecting the dots. Examiner is interested in asking some specific information. You go through those MCQs, connect the dots, like Pacinian corpuscle will detect pressure and vibration carried by which neural column in the spinal cord. Say I am taking a tuning fork, touching it here. That tuning fork vibration is rapid vibration. Which neural column will carry it to my spinal cord, and how it will reach the brain stem and my brain, so that I can feel the vibration. So my question, I hope you got the point. Pressure and vibration is carried by dorsal column in the spinal cord, and this dorsal column in the spinal cord will be reaching the brain stem to become medial lemniscus in the brain stem. So a question will come, they will be asking you, medial lemniscus is a continuation of, you say medial lemniscus is second order neuron, this is first order neuron. So medial lemniscus is a continuation of dorsal column in the spinal cord. What does it carry? It carries 5 sensations. So what are the 5 sensations which are carried by dorsal column? Can you mention in the chat? Because they are all MCQs. Tell me, you are connecting the dots. You should know each and everything about the dots. See, in the exam, MBBS is for 5 years. Examiner knows it is not possible for human brain to remember everything in a day what you have learnt in 5 years. So he will be asking very limited information again and again and again. And that limited information you can come to know which information they are asking again and again by practicing the previous year questions. And just remember, try to remember them. And it itself is too much for us. Human brain cannot remember everything at one particular moment of time. So what should we remember is known by practicing previous year questions. This is how we do it. Tell me the 5 sensations carried by dorsal column. Sir, please, on AC. What is AC? AC, air condition. Are you able to see the sweating? What is this AC? Touch. Which approach is good? Solving MCQs, daily subject wise, all subject wise. See, the best approach will be start with one subject and finish one subject in case of your FMGE exam. That is always better because you do not have much time for your exam. Start one topic and finish it off. And anyway, when you do anatomy, do you think you are only doing anatomy? This is anatomy plus physiology. This is anatomy, physiology plus medicine also, because Brown-Séquard syndrome is what? Is it anatomy, physiology or medicine? So you cannot actually segregate anatomy from physiology, but advisable is do one subject at a single go and then the other, and come back to anatomy again, because you should revise 2-3 times at least. Okay, good. So 5 sensations carried by dorsal column are pressure, touch, vibration, pressure, touch, vibration, stereognosis, conscious proprioception, pressure, touch, vibration, stereognosis, conscious proprioception, these 5 sensations, okay. Yeah, already you have answered. Sarthak has already answered it. Perfect. So as I say, yeah, fasciculus cuneatus is a part of dorsal column because upper limb, fasciculus cuneatus, very good. You are all brilliant people. Maybe what you need is a direction only to put you on track, because you are capable. You can very well take care of yourself. Only see, a teacher does nothing, just put you on track, give you a direction, and but you should become a good doctor. That is of paramount importance. You cannot be very superficial in your knowledge. This is very superficial thing. Eventually you will learn. Life is long, you will learn a lot of things, but your basics should be strong. This is all basics, okay? Fine, good. Anyhow, because there are questions on this, so that is why I started like that. But this question is on skin receptors. So let us talk about Meissner, Merkel and Ruffini also, because you get a question. Braille reading, which is the best receptor? Question number 1. Question number 2, which receptor do you use for Braille reading? There will be different answers. And how there will be different answers, that is also important to know. So as you go through the details, let me show you some diagrams. They will be helping us here. You see, this is keratin on the skin. This is stratified squamous epithelium on the skin. Stratified squamous epithelium on the skin, because skin has keratin. So this is the keratin. Same thing you can see here. This is skin epithelium, and this is the skin epithelium, which is stratified squamous epithelium. So what you see here is stratified squamous epithelium. That is called as epidermis. So here what you are looking at is epidermis, and below that is dermis. Now dermis will be two parts, superficial and deep. So there will be some receptor in the superficial dermis, and there will be some receptors in the deep dermis. There will be some receptor in the epidermis. For example, pain and temperature is carried by pain, and take a pin prick, pain is carried by. So pain and temperature will be carried by free nerve ending, and these free nerve ending, as you can make out yourself, they are in the epithelium. They are coming to the epithelium. That is how they can detect the pain and temperature. So free nerve ending, they reach the skin epithelium and they detect the pain and temperature. Now in the basal layer of epidermis, which is stratum germinativum, stratum basal, in the basal layer of the skin, which is stratum germinativum, or you call it as stratum basal because it is the basal layer. This one, basal layer. This one, basal layer. The basal layer of epidermis. Magnified Merkel cell. So where is Merkel cell found? Merkel cell, which you can see here, this is Merkel cell. Merkel cell is found in the basal layer or stratum germinativum, stratum basal of the epidermis. What does it do? I am holding a pen here, pencil here, light touch sensation. Merkel cell will detect that I am holding a pencil. Light touch sensation is carried by Merkel cell, and Merkel cell is slowly adapting. It is slowly adapting. So Merkel cell is slowly adapting, and it will take care of light touch sensation. Best receptor to read Braille. Best receptor to read Braille, but it can read only words, not the make sense out of sentences, because it is slowly adapting. Because Merkel cell is slowly adapting, it can help the blind people to read Braille, but only words, because it is slowly adapting. It cannot help you read sentences, and you have to read sentences to make sense of any language. So which receptor will help you to read sentences then? Question number 1 will be, which receptor is the best receptor to detect Braille character? You will say the Merkel is best receptor to detect Braille receptor, but it is slow. It can help you to read the words. It cannot help you read the sentences. For sentences you need a faster receptor. So another question comes. It will ask you, Braille is read by which receptor? Of course Braille can be read by Merkel also, but it is not the one which help us to read Braille. Braille is not reading words, it is reading sentences. So which one is helping you to read the sentences? Dermo-epidermal junction. It is at the dermo-epidermal junction, and as you say dermo-epidermal junction, that is what is called as the Meissner corpuscle. So this is Meissner corpuscle. This is Meissner corpuscle. Dermo-epidermal junction, or the upper dermis, superficial dermis. So in the superficial dermis, at the dermo-epidermal junction, you have Meissner corpuscle, and that Meissner corpuscle, this arrow mark is at Meissner corpuscle. It will help you read Braille faster, sentences. Question number 1, which is the best receptor to read Braille? Merkel. Which is the receptor you use for reading Braille? Meissner. There is a difference. Meissner is rapidly adapting. Now when you say Meissner is, this is Meissner corpuscle, and Meissner is rapidly adapting receptor, and it can detect the Braille characters. What else it can detect? The Meissner corpuscle is also for tactile discrimination, 2-point discrimination. So Meissner corpuscle can help us in 2-point discrimination. For example, in the CNS exam, you are touching the patient at 2 point, asking can you feel the 2 points? That is 2-point discrimination. That is also done by the Meissner corpuscle. And Meissner corpuscle can also detect low frequency vibration. Low frequency vibration. So if the Meissner is for low frequency vibration, which one is for high frequency vibration? That was the question, and that is here, Pacinian corpuscle. This is Pacinian corpuscle, deep dermis, deep dermis. As you will notice, this is onion skin appearance, onion skin appearance in the deep dermis, and I told you P for P. What is P for P? That Pacinian is for pressure, but not only pressure, it is also for vibration. So which vibration? It is high frequency vibration. In the deep dermis, you have a rapidly adapting receptor, and that rapidly adapting receptor is the Pacinian. So you have two rapidly adapting now. One in the superficial dermis, the Meissner, other in the deep dermis, the Pacinian. Both of them are rapidly adapting, and the Pacinian is for carrying pressure and vibration also, but high frequency vibration, and it is in the deep dermis. In the deep dermis, you have one more receptor, that is the Ruffini receptor. This is Ruffini receptor. As you can see, it is in the deep dermis. So what is the Ruffini receptor for? Ruffini receptor is for detecting skin stretch, dermal stretch, skin stretch. So if you stretch the skin, say for example, you are sitting on a chair for 2 hours. You are sitting on a chair for 2 hours. Wherever you are sitting, the skin is stretched. So if the skin is stretched for long duration, that will be detected by the Ruffini receptor, dermal stretch, and it is slowly adapting. It is slowly adapting. So now you have two slowly adapting receptor, Ruffini and the Merkel. Merkel is a slowly adapting receptor for light touch sensation, and Ruffini is for dermal stretch in the skin. But both of them are slowly adapting, and these two are rapidly adapting, the Meissner and the Pacinian. So these are all MCQs. I hope you got my point when I say that when you practice one MCQ, you should practice 10 MCQs. And how do you do that? Go through the previous year questions. It will happen automatically. These things happen automatically. Anyhow, now it is skin receptor essential for detecting rapid vibration. You already have answered. It is Pacinian corpuscle, yes. But Pacinian is also carrying pressure. So pressure and vibration. Can you tell me what is Meissner corpuscle doing? First answer should always be Meissner corpuscle is for tactile discrimination, 2-point discrimination. Then what is the second answer? Meissner corpuscle is also helping us in detecting low frequency vibration, slow vibration. And what is the third answer? Meissner corpuscle is also helping us to read Braille, read the Braille. So Meissner corpuscle is rapidly adapting receptor, and it is for 2-point discrimination, first answer. It can also detect the low frequency vibration, slow vibration, and it can also help us in reading Braille. Though the best receptor for reading Braille is Merkel. Merkel is the best receptor for reading Braille, but it does not help us to read Braille, because to read Braille you have to read sentences. It cannot help us reading sentences, it can help us in reading word only. If they ask you best receptor for reading Braille, maybe Merkel, but which receptor do you use for reading Braille? Is the Meissner. What is Merkel cell basically for? Light touch sensation. It is for light sensation. For example, holding a pencil in your fingers is detected by Merkel cell. And what is the Ruffini for? Ruffini is for dermal stretch. It is a slowly adapting receptor. Slowly adapting, and the first two are rapidly adapting. So these questions can be your physiology question also. Actually, your physiology teacher will also teach you the same thing. Dr. Manna will be taking care of this in addition to me. But Dr. Manna may not be going in so much of detail of the histology. So taking care of histology is my job, because if a marker is given here, maybe he will not be telling you those details. These details come into territory of anatomy. Not a very difficult question. Tell me the answer here. Yeah, tap and flutter. Yes. PSMU Russia. Good afternoon, sir. Good afternoon. AB. Why AB? This is pubis symphysis. And what is pubis symphysis? Midline joint. So this question came FMGE August and December 2020. So questions keep repeating themselves sometime. This is pubis symphysis, and it is basically symphysis. So secondary cartilaginous joint. Secondary cartilaginous joint. Now once you know that it is symphysis and secondary cartilaginous, what about the primary? What about the fibrous? What about the synovial? That's what we do. Doing one MCQ, normally the mistake which we do is, and we think that sir told us practice MCQs. I am practicing MCQs. And how are you practicing MCQs? I read the question, I look at the answer, this is my answer, let us go to the next question. I am practicing MCQs. No. Not only should you know the answer, you should know why this is not the answer, why that is not the answer, when they will become the answer. Asking yourself what, when, why, how is learning. Learning is not just trying to memorize things. Learning is to ask questions to yourself. Okay. Anyway, so as we proceed further, maybe this is, you may be irritated that all the time we keep telling you same things again and again and again, and you are frustrated and what is this? But let me ask you a question. Suppose you become an orthopedician and you become a very good specialist at TKR, total knee replacement. What will you be doing? Daily 10 TKR you will be doing, and you will be frustrated even then. It's been 20 years, every day there are 10 patients, TKR. You open the knee, close the knee, open the knee, close the knee, put some implants, close it. What is that? That is also same thing. Will you be frustrated, irritated? And see, life is to learn something and keep doing it again and again and again and again. So what is the harm in reading this again and again? Ask me. I have taught this topic at least 1,000 times. This is 1,001 time. And look at the energy, intensity, the will, the enthusiasm to teach you the same, with same energy which I taught in first class. That is professionalism. You have to learn that. Maybe this you are doing 1,000 times, but the patient who comes to you for TKR, has he undergone TKR operation 1,000 times? He is first time, that is his first time. So you also have to treat it as your first time. That enthusiasm should be persistent. So don't get frustrated, don't get irritated, don't get bugged up that what is this, the same thing we keep doing again and again, what is happening? That is life. That is life. Do you agree or not? ये तो खुद को ही मामू बनाने वाली बात. तो भाई इस जिंदगी में हाँ ये है कि कुछ लोग दूसरों को मामू बनाते हैं, पर मैक्सिमम टाइम आप खुद को ही मामू बना रहे होते. देखो जिंदगी की हकीकत अक्सर कड़वी होती है, काफ़ी कम लोग ही बोलते हैं. इसका मतलब ये नहीं कि ज़िंदगी कड़वी है, ज़िंदगी मीठी भी है, ऐसा नहीं है. बट दैट इज़ द रियलिटी. 50 साल उम्र हो गई मेरी, 50 क्रॉस कर गया. अब तो समझ में आ ही गया है कि कर क्या रहे हो आखिर. हाँ, पुराने ज़माने में एक चीज़ अच्छी होती थी, जब कंपटीशन नहीं था. 10 years you become a surgeon. After 10 years you got fed up. What is this, doing TKR all the time? Then you become a physician, physicist, and you start discussing that how light is created, how a bulb is created, what is this filament here, tungsten filament, all that. And after 10 years you are fed up with all this physics, become a chemist. Become a chemist, and then you start discussing what is this calcium carbonate doing, and how much of hard water is there and all that. So next 10 years you are a chemist. Next 10 years you are a botanist. You grow plants, and this is Mangifera indica, and this is the scientific name of plants. That was beautiful life. But now we have become so specialized that we have lost the charm of life actually. So anyway, let us come back, and what you see here is classification of joints. See, joints can be basically solid joints which are almost immobile or slightly mobile, and then there can be freely mobile joints which are synovial. So here we are not discussing the freely mobile or synovial joint. Here we are discussing the joints which are solid, which may be immobile or slightly mobile. So what are the classification? Under that you have fibrous and cartilaginous. In fibrous 3, in cartilaginous 2. Question was on this one, pubis symphysis. So when you say solid joints which may be immobile or maybe slightly mobile, in the fibrous variety, 3 types. The very first is suture, that can be seen in the skull, and the other is tooth and socket joint, which is gomphosis. So skull joint, sutures, and tooth and socket, gomphosis, they are immobile, they don't move. When the 2 bones make a suture in adult, they don't move, immovable, and gomphosis is immobile. You cannot move your tooth in the socket, that is not possible until you have some problem like caries and all that. Normally it should not move. But syndesmosis, desmos means fiber, fibrous joint. Syndesmosis, fibrous joint, they are slightly mobile. One example, middle radial ulnar joint, middle radial ulnar joint. Another example which examiner asks is inferior tibiofibular joint. So middle radial ulnar joint is a syndesmosis, and inferior tibiofibular joint. Now middle radial ulnar joint is between radius and ulna, and it will help you in supination, pronation. Supination, pronation, slightly. So middle radial ulnar joint, which is a syndesmosis, which is a fibrous joint, it is slightly mobile joint, and so is inferior tibiofibular joint, and they are slightly mobile, and they help in some component of movement. Though supination and pronation happen chiefly at synovial joints, because synovial joints are freely mobile joint. So which synovial joint will be helping in supination, pronation? Superior, inferior radial ulnar joint. So superior and inferior, because in an anatomical position this will be superior, that will be inferior. So superior inferior radial ulnar joint is basically for pronation supination, helped by middle radial ulnar joint, which is slightly mobile, and it is a syndesmosis. This is about fibrous joint. What about the cartilaginous? Cartilaginous, primary synchondrosis, secondary symphysis. Primary synchondrosis, secondary symphysis. So how do you define synchondrosis? As you see, let us draw. You will find a part of bone which is epiphysis, a part of bone which is diaphysis. Diaphysis means shaft, epiphysis means end of the bone. So as you can notice, there is a shaft of the bone, diaphysis, end of the bone, epiphysis, and connecting the two, you will find there is some cartilage, and that is hyaline cartilage. That hyaline cartilage is the growth plate. So we are calling it as growth plate. This is growth plate. This is the growth plate. Epiphysis diaphysis joint. Epiphysis diaphysis joint in the growing children. Shaft of the humerus, head of the humerus. Between the shaft of the humerus, head of the humerus, you have a growth plate in the growing children, and that growth plate is made up of hyaline cartilage. That growth plate which is holding one bone with other bone. Epiphysis with diaphysis. Epiphyseal-diaphyseal joint is a primary cartilaginous joint. Primary cartilaginous joint, synchondrosis. Then what about the secondary cartilaginous? Secondary cartilaginous is here, symphysis. This was your question. So your question was on symphysis, secondary cartilaginous. How do you identify that? Like pubis symphysis. Let us draw pubis symphysis. You will find there is one hip bone, right hip bone, there is left hip bone, the pubis part of hip bone. So right and left pubis part of hip bone, in the midline they come, and they are covered by what you call as the hyaline cartilage. So each bone, each hip bone is covered by hyaline cartilage, and between the two you have one more cartilage which is the fibrocartilage, So this is fibrocartilage, and these are the hyaline cartilage. This kind of a structure where you have one bone connected with other bone, each bone lined by hyaline cartilage, sandwiching fibrocartilage, is a secondary cartilaginous joint. See here the two bones, what was between them? Only hyaline cartilage. Between the two bones you have only hyaline cartilage, but here not only you have hyaline cartilage, you have sandwiching fibrocartilage. So this becomes secondary cartilaginous joint. Usually they are in the midline. One is pubis symphysis, second is midline intervertebral joint. When you say midline intervertebral joint, you will find each vertebra is itself lined by hyaline cartilage, but between the hyaline cartilage you have a intervertebral disc, and that intervertebral disc is made up of fibrocartilage. So each vertebra is a bone, midline intervertebral joint. Each vertebra is already lined by hyaline cartilage. What is sandwiching between the two is fibrocartilage. What is that fibrocartilage? Intervertebral disc. And let me tell you again, though we are taking care of one MCQ here, but we have already taken care of 10 MCQs. This is how I do it, this is how you should do it. So which type of joint is present at the arrow mark? Symphysis. What is the answer? Secondary cartilaginous. The other name is symphysis. What about the choice A? Choice A, if you ask me, then it is called as synchondrosis. Can you give the example of synchondrosis? Yes, epiphyseal-diaphyseal joint in the growing children. So primary cartilaginous synchondrosis, epiphyseal-diaphyseal joint in the growing children. What about the fibrous joint? Fibrous joints we have discussed three types. What are the three types of fibrous joint? The suture and gomphosis and syndesmosis. So fibrous joint, sutures, gomphosis, immobile, but syndesmosis slightly mobile. What are the two examples of syndesmosis? Two examples of syndesmosis: middle radial ulnar joint, inferior tibio fibular joint, slightly mobile. What about synovial? Synovial joint are freely mobile. For example, superior inferior radial nerve joint, they are pivot synovial joint, pivot, P-I-V-O-T, pivot. Pivot synovial joint, superior inferior radial nerve joint are synovial, freely mobile, and they help in supination pronation. Okay, then this question: which type of collagen is found in the joint capsule? FMGE, June 2021. Tell me the answer. Sir, growth plate is also called epiphyseal plate. Yes. Actually, the part of metaphysis and not epiphysis. See, growth plate, if you say it is a part of metaphysis, yes, not epiphysis. Correct. कौन सा क्लियरिंग, कौन सा CLG है आपका? CLG क्या होता है भाई? ये शॉर्ट फॉर्म वाले जमाने के नहीं हम लोग, हम थोड़ा बूढ़े लोग हैं. फुल फॉर्म लिखो. क्या मोटिवेट किया सर? हाँ, मोटिवेट मैं ऐसे करता हूँ, पढ़ा पढ़ा के. वैसे मोटिवेशन की कहानियाँ मुझे आती हैं, पर मैं वो कहानियाँ नहीं सुनाता ज़्यादा. टाइम खराब हो जाता है. Yes, it is a profession, medical profession. 24/7 we have to keep ourselves self motivated. Okay. हाँ, so आंसर बताओ भाई. A. Okay, so let us look at a table first, and maybe then we can come back here. Type 1, 2, 3, 4. Examiner is usually interested in asking 4 types of collagen. Most common is type 1, and best example is bone. So usually the examiner will be asking 4 type of collagen, type 1, 2, 3, 4. Most common of them is in our body is type 1, and one good example is bone. But remember, if you are talking about the cartilage, then cartilage will have predominantly type 2. But then again, remember, when you say cartilage is having predominantly type 2 collagen, we are talking about the hyaline cartilage and elastic cartilage, not the fibrocartilage. So type 2 collagen is in the cartilage, but only in hyaline elastic. What about the third type, fibrocartilage? No. Fibrocartilage is atypical, and because it is atypical, you will find that fibrocartilage is behaving like bone, and it has more of type 1 collagen. So as I repeat once again, you can see for yourself what I am talking about is bone will have type 1 collagen, even fibrocartilage will have type 1 collagen predominantly. It is atypical cartilage. Now why would you say it is atypical cartilage? Because it behaves like bone. It behaves like bone means what? Means like bone it has more of type 1 collagen. And what else? Like bone, it will have neurovascular bundle. Neurovascular bundle is seen in fibrocartilage. Why? Don't you have neurovascular bundle in the cartilage? No, you don't have. You don't have any neurovascular bundle in hyaline or elastic cartilage. You take the hyaline elastic cartilage, cut it, no blood will come, no pain will come. Why? Why cutting the hyaline cartilage, elastic cartilage, there is no blood coming, no pain is having, the individual is not having any pain? Because they don't have nerves, they don't have blood vessels. So you mean to say fibrocartilage will have blood vessels and nerves? Yes, just like bone is having. So bone is vascular, bone has nerves. If you break the bone, there will be bleeding and there will be pain. Same thing happens with fibrocartilage. Okay, so what about the collagen? Collagen, I am telling you, bone will have type 1 collagen. Fibrocartilage will have type 1 collagen predominantly, but type 2 collagen is in the cartilage, especially elastic and hyaline. Then where is type 3? Type 3, if you ask me, then you can mention, let us take some other color. Type 3 collagen can be seen, they are also called reticular fibers. First of all, they are also called reticular fibers, and these reticular fibers, type 3 collagen, can be seen in lymphoid organs. Lymphoid organs like what? Lymphoid organs like liver and tonsil and spleen. And is it seen in thymus? That comes as a question. Remember, thymus do not have reticular fibers or type 3 collagen. So reticular fibers type 3 collagen are found in lymphoid organ, could be liver, tonsil, spleen, lymph node. It can be lymph node also, but remember that you do not have the reticular fibers or type 3 collagen fibers in thymus. That comes to the question. Okay, where else do you find type 3 collagen? Type 3 collagen is also found in recent healing tissue, granulation tissue. Now, once you say that type 3 collagen is also found in granulation tissue, which is recent healing tissue, I ask you a question, what about the old scar? What about the old scar? Which collagen in old scar? If you are mentioning that the recent healing tissue is having type 3 collagen, what about the old scar? In old scar, type 1. In old scar, type 1 collagen. So these are all MCQs, may not have been yet asked in FMGE, and they are questions in INI-CET, NEET PG, but be careful. People who take your FMGE exam, they also follow NEET exam and INI-CET exam. Some easy questions they can pick from there, though when I say easy, it may be easy for me, not for you, but it is an easy question. So what is the question? Question is recent healing tissue, which collagen? You say type 3, and old scar, then type 1. What about type 4? Type 4 can be seen in basement membrane. Now when you say type 4 is seen in basement membrane, a question comes like Alport syndrome in the kidney. So which collagen is compromised? Type 4 collagen is found in basement membrane. In Alport syndrome, glomerulonephritis, there can be problem with basement membrane because type 4 collagen is compromised. In osteogenesis imperfecta, there can be problem of type 1 collagen because it is a problem of bone, brittle bones. So brittle bones, example, osteogenesis imperfecta. So osteogenesis imperfecta, brittle bones, which collagen problem? Type 1. I'm not going to pathology section here too much, but these are some of the things which we should remember. Okay, what about the question? Remember, type 1 collagen is also found in capsules. Now when you say it is found in the capsule, what capsule are you talking about? Type collagen is the most common collagen in capsule. Capsule of what? Capsule of any viscera or capsule of the bone. What is this capsule of the bone? The one which covers the bone. Yeah, what covers the bone? Periosteum. Okay, are you telling that periosteum will be type 1 collagen? Yes. Yes. Now bone is type 1 collagen. Yes. And covering the bone, some capsule which you are calling as periosteum is also type 1 collagen. Yes. And if you know that, let us look at this diagram now. As you look at this diagram, this maybe we have taken the diagram of knee joint. Let us assume that we have taken the diagram of knee joint. Upper bone, femur, lower bone, tibia. Upper bone, femur, lower bone, tibia. So this is male, the femur, and lower, female, the tibia. And what they make? The knee joint. Knee joint is a synovial joint filled with synovial fluid. So to keep the fluid there, you must have a capsule connecting the bones. So this is the capsule connecting the bone. Femur bone connected with tibia bone. femur bone connected with tibia bone. So this is capsule. Tell me which collagen. Capsule is type 1 collagen. Yes, very good. So capsule is type 1 collagen. What is this bone covered by? Capsule. What is the name of that capsule covering the bone? Periosteum. And in the periosteum, what is the collagen? It is again type 1. In fact, you have to understand the periosteum. When you talk about this periosteum do not enter the joint. Inside the joint, there is no periosteum lining the bone. If periosteum is not lining the bone, then where is periosteum going? Periosteum becomes continuous with the capsule, and then capsule becomes continuous with the periosteum. You mean to say you don't have periosteum inside the joint? Then what is the bone lined by? There, the bone is lined by the synovial membrane. So you can show some other color that inside this bone is lined by synovial membrane. There is no periosteum. So you are mentioning that there the bone is having synovial membrane. Yes. And no periosteum. No. What is this? This is not synovial membrane. Yes. Actually, each bone in a synovial joint should be lined by hyaline cartilage. And what is that hyaline cartilage doing? That hyaline cartilage is known as the articular cartilage. Let us take some color, maybe let us take black only. So this is the articular cartilage, and this articular cartilage should cover the bone. Why the articular cartilage should cover the bone? So that they become smooth and there will be smooth movement. Knee flexion, knee extension. So knee flexion, knee extension, if you want to do that, each bone should be lined by articular cartilage, which is hyaline cartilage. I ask you now, if this is articular cartilage, if this is hyaline cartilage, which collagen is there? Which collagen? Because it is hyaline cartilage, it will be type 2 collagen. It will be type 2 collagen. Now, this is articular cartilage, it is hyaline cartilage, it is type 2 cartilage. Can you tell me which collagen do you find in this cartilage, which I will be shading now, this cartilage? Tell me. Sir, what is this? This is knee meniscus, knee joint, knee meniscus, and knee meniscus is fibrocartilage. Now, when I say knee meniscus is fibrocartilage, you know, fibrocartilage is atypical cartilage. So which collagen? And your answer, intra-articular disc or knee meniscus, fibrocartilage, so type 1 collagen. Now, in a single diagram, you have discussed several questions. I will repeat again. Questions can be periosteum, which collagen? You say periosteum has the same collagen as the bone. Okay, then what is in the bone? Type 1 collagen. So where do you have type 1 collagen? Bone, periosteum, capsule, and fibrocartilage. Once again, where do you have type 1 collagen? Type 1 collagen, bone, periosteum, capsule, and the intra-articular disc or knee meniscus. Okay, where do you have type 2 collagen? Type 2 collagen, articular cartilage, which is usually hyaline cartilage. So articular cartilage is usually hyaline cartilage, will have type 2 collagen. That is all I wanted to discuss. Go back to the question. What is your answer? You already would have answered it, but let us do it again. Which type of collagen is found in joint capsule? Same as capsule of the bone, which is periosteum. Same as the bone itself. Okay, so what is the answer? Type 1. If it is type 1, where do you find type 2? Hyaline cartilage, elastic cartilage, like meniscus, knee meniscus. Sorry, this is type 2. So articular cartilage, articular cartilage. So articular cartilage is made up of hyaline cartilage. And what is hyaline cartilage? Type 2 collagen. Where do you see type 3? Type 3 I find in lymph node but not thymus. In lymph node but not thymus. Where else do you find type 3? I find it in the lymphoid organs, and also I find this cartilage in recent healing tissue, granulation tissue. Recent healing tissue, granulation tissue. And type 4? Type 4 you already know, something like basement membrane. Something like basement membrane, Alport syndrome and all that. What is the difference between capsule of a joint and a bursa? Say if you are asking about the bursa, bursa is related with the skin. It may be over a joint and it is lined by synovial membrane. So you cannot say about the collagen fibers as such because it is lined by synovial membrane. I'll repeat again, your question is difference between capsule and a bursa. Bursa also have type 1 collagen, that is your question. Though I have to think over it, you have got a good question here, but let me tell you one thing. So this is a bone, this is another bone, and you have a capsule connecting the two here, and then over that you have the skin. This is skin. Okay, let me show you here. This is one bone, other bone, maybe knee joint, covered by capsule. Over that you have skin. On the knee joint you have skin. Now under the skin you have got, under the skin you have got a bursa, suprapatellar bursa, prepatellar bursa. So suprapatellar bursa, prepatellar bursa, skin and bone, between the two you have a space lined by synovial membrane. It is lined by synovial membrane. So I cannot actually comment upon the collagen fibers here. Maybe it is type 1, I can agree with you, maybe because most of the time in our body is mostly type 1 collagen, but it is basically lined by synovial membrane. And why do you need it? I need it because when I move my joint, skin will rub against the bone. It must be free movement of the skin. So when the skin rubs against the bone, there should be some free movement. So synovial fluid or synovial membrane will keep it smooth movement. That is the purpose of a bursa. It will be filled with synovial fluid actually. Okay, and if you ask me what is the lining of synovial bursa, is it the same as the capsule? I will have to explore it, but I can, if you want a safe option, maybe bursa is lined by synovial membrane and also collagen type 1, because if you don't know answer to any question, type 1 is a safe option because type 1 is the most common type, but that is not how you should approach. Until and otherwise you read in a book, written in a book, in a standard textbook like Gray's Anatomy, you should not tell things like with thinking on yourself and just telling things like that. That is wrong. So maybe I am doing a wrong thing here because I have not read anything about the collagen lining the bursa. So I cannot answer your question. But safely type 1 collagen may be a safe option, but nobody will ask you as such. I really doubt that. सर आपके हाथ में क्या हुआ? हाथ में कुछ नहीं हुआ, ये पाम रिजेक्शन के लिए होता है. आप जब किसी टच स्क्रीन पे काम करते हैं तो आपका सिर्फ उंगली ही डिटेक्ट होनी चाहिए, पाम नहीं होना चाहिए. ये मैं यहाँ पे रखूँगा तो डिटेक्ट नहीं करेगा, यहाँ तो कर रहा है क्योंकि ये अलग स्क्रीन है. मेरे कंप्यूटर स्क्रीन पे सिर्फ मेरी उंगली ही डिटेक्ट होगी. ये पाम रिजेक्शन है, ये मेरे पाम को डिटेक्ट नहीं करता. अगर मैं पाम रख दूँ इसके ऊपर तो डिटेक्ट नहीं करेगा, नहीं तो ये हिलता रहेगा. पाम रिजेक्शन ग्लव्स. ये क्रिस्टल क्लियर तो आजम सर वाला है. हाँ जी बिल्कुल सही कहा, आजम सर भी अच्छा पढ़ाते हैं तो बढ़िया है. हर टीचर की अपनी खासियत है. तो क्लॉ हैंड, अल्नार क्लॉ हैंड, यस. अगर यही दो फिंगर्स इन्वॉल्व हुई हों तो अल्नार क्लॉ हैंड की बात कर सकते हैं. बिल्कुल सही है. लास्ट अटेम्प्ट 147, ये गड़बड़ है. ये 147 की कहानी मेरे को आज तक समझ में नहीं आई, पर चलो खैर कोई बात नहीं. देखो लास्ट अगर 147 है तो इस बार 207 है. मुझसे लिखवा के ले लो. एक काम करना पड़ेगा लेकिन पिछली बार 147 है, इस बार 207 है। एक काम करना पड़ेगा, काम वो है थोड़ा आसान ही है, ज़्यादा मुश्किल नहीं है। कम से कम हमारे डिस्कस किए हुए प्रीवियस ईयर क्वेश्चंस FMGE के जितने भी हैं सारे YouTube पे मिल जाएंगे। इंटू 2 स्पीड पे देख लो, इंटू 2 स्पीड पे 2 बार, एक बार में काम नहीं चलता, 2 बार। और सिर्फ एनाटॉमी नहीं, मतलब एनाटॉमी पढ़ के ही हो जाएगा ऐसे नहीं, सारे सब्जेक्ट। मतलब कुल मिला के सारी कहानी ये है कि प्रीवियस ईयर क्वेश्चंस को 2-3 बार आप प्रैक्टिस कर लो। 147 के 207 आराम से हो जाएंगे। ज़्यादा मुश्किल एग्ज़ाम नहीं है आपका। प्रॉब्लम सिर्फ ये है, 2 प्रॉब्लम है। प्रॉब्लम नंबर 1 क्या है, FMGE एग्ज़ाम क्लियर करने में जो प्रॉब्लम्स आती हैं, प्रॉब्लम नंबर 1 ये है कि आपको पता नहीं कि क्या करना है। वो मैं बता रहा हूँ, स्मार्ट वर्क करना है। स्मार्ट वर्क क्या है, प्रीवियस ईयर क्वेश्चंस करने हैं। और नंबर दूसरी प्रॉब्लम है हार्ड वर्क करना है। स्मार्ट वर्क और हार्ड वर्क करोगे तो रैंक मतलब रैंक तो क्या, यहाँ पे तो पास ही होना है। अब ये स्मार्ट वर्क और हार्ड वर्क क्या है, कुछ नहीं है। प्रीवियस ईयर क्वेश्चंस करने हैं और शिद्दत के साथ करने हैं। हार्ड वर्क का मतलब ये होता है कि हर रोज 100 क्वेश्चन करने हैं, वो हार्ड वर्क हो गया। हार्ड वर्क स्मार्ट वर्क करोगे ऑटोमेटिकली हो जाएगा, आपको पता नहीं चलेगा कब गाड़ी और कब चलेगी और कब आप गाड़ी में बैठ गए, फर्स्ट क्लास गाड़ी में बैठ गए। तो अब आप कहोगे कि सर आपके लिए तो बहुत आसान है क्योंकि आप तो ऑलरेडी कर चुके हो। तो ऐसा नहीं है, आसान तो कुछ भी नहीं है, आसान कुछ भी नहीं है। लेकिन स्मार्ट वर्क और हार्ड वर्क और अप्रोच आसान है, करते हुए मुश्किल है पर अप्रोच आसान है। और अप्रोच सिर्फ एक ही है, सारे स्टूडेंट्स के लिए एक ही मैसेज है, प्रैक्टिस प्रीवियस ईयर क्वेश्चंस एज मच एज पॉसिबल। रास्ता आसान हो जाएगा। ओके ओके, एनीवे 130, 145, 146 भाई ये ज़िंदगी की व्यथा है, ज़िंदगी का दुख है। और ऐसा नहीं कि हमने नहीं झेला है, हार हमारी भी हुई है, ऐसा नहीं कि, लेकिन हार के आगे जीत है, ड्यू। ओके, न्यूरो। Patient with lesion in paracentral lobule, which part of the body is most likely affected? यहाँ पर homunculus की बात हो रही है। homunculus, homunculus मतलब जो body है, head, trunk, upper limb, lower limb, इसका representation. So in a patient who has a lesion in the paracentral lobule, paracentral means there is a central line and around the central line, paracentral. Cerebrum की बात हो रही है, cerebrum. In the cerebrum, paracentral lobule, so well the problem. Now it is about the homunculus, which could be motor or sensory. Homunculus, which is motor as well as sensory, representation is same. It is upside down. Upside down means body represented upside down. See, normally head is up, this is upper limb, this is lower limb, and this is the trunk region. But on the brain, it is represented upside down. So as you can see, this is the head, this is upper limb, this is lower limb, anatomical position, but in homunculus on cerebrum it is represented upside down. So what do you mean by that? You will see, let us just look at cerebrum. Say this is the diagram of cerebrum looking from lateral view, so lateral sulcus will be there. Looking from lateral side, so lateral sulcus. This is lateral sulcus on the cerebrum, and then there is a central sulcus. It runs anterior inferior. So running anterior and inferior, running anterior inferior, running anterior inferior is central sulcus, and central sulcus will divide frontal lobe on the front, parietal lobe posterior. Frontal on the front, parietal posterior, and imaginary line occipital lobe, and below the lateral sulcus temporal lobe, 4 lobes. So this is lateral lobe, lateral sulcus. Below lateral sulcus you have temporal lobe, temporal bone ear, temporal lobe, and this is for hearing. Occipital lobe for vision, looking vision comes here. Frontal is motor, so move the muscle, it will be moving the muscle, and whatever sensations come, parietal sensory cortex, parietal sensory cortex. But then body is represented on cerebrum upside down. When you say body is represented on cerebrum upside down, what do you mean? What I mean is the head will be inferior, this is upper limb, and that is perineum, and you cannot see lower limb from this view. So representation of head, upper limb and perineum can be seen. You see this is head, and that is upper limb, and that is perineum, but you cannot see lower limb. Why? Because lower limb is on the medial side, on the medial side. If there is any block of artery here, say middle cerebral artery, because middle cerebral artery supply here, so the artery which supply here is middle cerebral artery, and if middle cerebral artery is blocked, there will be a sensory motor problem on face, sensory motor problem on the upper limb, but there will be no sensory motor problem on the lower limb. Why? Middle cerebral artery is blocked, which supply lateral cerebrum supply, head area, upper limb area, but not the lower limb area. Why not lower limb area? Because for lower limb area, you have another artery which is called anterior cerebral artery. There is one anterior cerebral artery which will supply the lower limb area. And how the anterior cerebral artery will supply lower limb area? It supplies some part of the cerebrum here, including the perineum, this area. It will supply including the perineum and lower limb. So that means it will supply lower limb. Yes. And if there is a block in anterior cerebral artery, then the lower limb will have sensory motor problem. Not only lower limb, but also pelvis perineum. Difficulty, urination, defecation. Difficulty, urination and defecation. If there is a block in anterior cerebral artery. Anterior cerebral artery supply medial side of the cerebrum, not the lateral. Lateral cerebrum supplied by middle cerebral artery, and medial cerebrum supplied by anterior cerebral artery. Let me show you some diagrams now. As I discussed, you can appreciate looking from lateral side. So this is the, let us take which color, white color. This is the lateral sulcus here, lateral sulcus, and then you have the central sulcus, frontal lobe, motor activity, parietal sensory activity, temporal hearing, and occipital vision. Body represented upside down. If you say head and upper limb, then it will be detected here. Say this will be the head area and this will be upper limb area, but not the lower limb area. Because if you are talking about the lower limb area, body upside down, it will be on the medial side. Medial side means where? Medial side means it will be on this side. Now what is this? Here you have taken a sagittal section of brain, removed the left half of brain. You have taken a sagittal section of brain, removed the left half of brain, looking at the right half of brain now. So this is medial view of cerebrum. And what is the major artery here? Major artery here is anterior cerebral artery. So anterior cerebral artery is the major artery on medial cerebrum. And on the medial cerebrum, can you show the central sulcus? Yes, central sulcus, if you want to see, it will be somewhere here. Now if that is the central sulcus encroaching from lateral to medial side, what will be on the frontal lobe, and what will be posterior, the parietal lobe, and which part of body will be represented here? The lower limb. So here you will have the representation of lower limb. This is called as paracentral lobule. This is called as paracentral lobule. So you mean to say paracentral lobule is on the medial cerebrum? Yes. And which area is it, motor or sensory? Partly motor and partly sensory. So if I have a block in anterior cerebral artery, there will be a ischemia in medial cerebrum. Yes. So there will be sensory motor problem on the lower limb. Yes. And pelvis perineum. In pelvis perineum also, difficulty in urination should be your first answer. Defecation your second answer. So there will be problem of urination defecation. Why? Because urination defecation happens by pelvic viscera, and this is where you represent pelvis. Pelvis, perineum, lower limb. Pelvis, perineum, lower limb is on paracentral lobule. So any block of this artery, there will be difficulty urination, defecation, and lower limb sensory motor problem. That gives you the answer to the question. Question is here. It is asking something, and whose answer you already know. Patient with lesion of paracentral lobule, which part of the body? So you will say perineum and lower limb. This will be the best answer. Now the diagram which you have seen, sometimes the examiner is asking more details. And what details the examiner is asking? Say in this diagram only, they will be asking you what is this? Tell me what is this in the chat. How to crack NEET? Same advice, smart and hard work. Practice as many MCQs as possible. Corpus callosum, very good. Can you tell me what is the major artery supply to corpus callosum? Can you tell me what is the major artery supply to corpus callosum? There is nothing much to think. Anterior cerebral artery, though partly this part will be supplied by posterior cerebral artery. There is a posterior cerebral artery also. So that part which is splenium part of corpus callosum, splenium part of corpus callosum is supplied by posterior cerebral artery, but major artery supply on medial cerebrum is anterior cerebral artery. If you block the anterior cerebral artery, there will be a problem with corpus callosum. Corpus callosum connects right brain with left brain. It is a commissural fiber. It is a commissural fiber connecting right brain with left brain. So communication of right left brain will be a problem. This is corpus callosum, which is commissural fiber. There is one more commissural fiber which examiner is interested in asking. It will be something like this. What is the name of this? Tell me. This is also commissural fiber, though it is not only commissural fiber, it has other set of fibers also, but this is the location. Tell me what is the name of this structure? Fornix, very good. Fornix, connecting right hippocampus with left hippocampus for short term memory. Hippocampus, short term memory, connecting right hippocampus with left hippocampus, fornix. What is the major artery supply to fornix? Major artery supply to fornix, again anterior cerebral artery, partly posterior cerebral artery. So posteriorly, maybe posterior cerebral artery, but if one answer you need, fornix is supplied by which artery? First answer should always be anterior cerebral artery. So these are some of the questions which are coming recently. Now for FMGE, actually sometimes they ask you very simple questions. Let me rub this off and then it will be better. They'll ask you something like, superior colliculus, inferior colliculus. Superior colliculus, inferior colliculus. Which part of brainstem is that? That is superior colliculus, inferior colliculus. Which part of brainstem is that? Superior colliculus, inferior colliculus. So this is midbrain. If that is midbrain, where is pons? Pons are here. Pons. If that is pons, where is medulla oblongata? If you are searching for medulla oblongata, then this is medulla oblongata, which passes through foramen magnum and then continue as spinal cord. This is medulla oblongata. Let me zoom this area now. So as we zoom this area, you will see we are looking at the brainstem. What are the three parts of brainstem? And your questions in FMGE questions are arrow mark here, arrow mark here, arrow mark here. What is this? What is this? And one more arrow mark. So this is three parts of brainstem. Midbrain identified by the fact that it has superior inferior colliculus. If you wish, I will rub it and you can see for yourself, because obviously in the exam you will not have this marking. You will have to see it yourself. Can you see yourself superior inferior colliculus of the midbrain here? This is pons. This is medulla oblongata passing foramen magnum to continue downward as spinal cord. If you want spinal cord will be still inferior. This is spinal cord in the vertebral canal. That will be spinal cord in the vertebral canal. But remember, foramen magnum is crossed by lower medulla, not the spinal cord. Spinal cord is inferior to that. Now, what is this? That was a question to you. Nothing else but cerebellum. If that is cerebellum, what is sandwiched between cerebellum posteriorly as the roof, brainstem anteriorly as the floor? And you can say that is none other than the fourth ventricle. This is fourth ventricle. So fourth ventricle is sandwiched between cerebellum posteriorly, pons and medulla anteriorly, and this fourth ventricle is filled with CSF. So these are some questions which come to you. For us, for me, it will be very simple question, and if you have practiced MCQs, for you also it will be simple, but everything becomes simple once you have gone through it. Before you have gone through it, it is difficult. So just practice more and more MCQs. I am not spending much time here, and you can look at this question. I think you already have answered, so no problem. Because it was paracentral lobule, your answer should be lower limb and pelvis perineum supplied by anterior cerebral artery. So no issue with this question. But then this question is here. It is a transverse section of the brain, and the transverse section of brain, they are asking you the correct sequence of structures, and FMGE June 2021. Now this kind of pattern is it is not FMGE pattern. They have copied it from INI-CET. INI-CET people do such things. 1, 2, 3, 4, A, B, C, D, arrange in a sequence, medial to lateral, proximal to distal. So as I told you, don't think that you cannot have questions from exams like NEET PG or INI-CET. You can have questions from there, though they will not ask you the very tough questions, but they can repeat. So I don't think there will be a much problem if you already have discussed such kind of diagrams earlier. And if you just want to focus here, let me demarcate the boundaries which we are supposed to. Again, I will tell, if you already have done this type of diagrams, it is easy for you, and if you have not done, then it is very difficult. So कोई भी माँ के पेट से जब पैदा होता है तो सब कुछ उसको पता होता है, ऐसा नहीं होता। आप बाहर आते हो उसके बाद ही सीखते हो, और जब सीख जाते हो आपको लगता है सब तो आसान है, और जिसको नहीं पता उसको सब मुश्किल है। आपको ये नहीं भूलना चाहिए कि वो भी आपके लिए मुश्किल था कभी, और कभी अगर ये आप नहीं भूलते कि आपके लिए भी मुश्किल था कभी, तभी आप पढ़ा पाओगे। एक टीचर तभी अच्छा टीचर हो सकता है जब वो ये ना भूले कि एक समय था जब मुझे भी नहीं मालूम था, आज मालूम है। तो ये सोच के चलना होता है कि तुम्हें अभी नहीं मालूम है, पर मुझे मालूम है कि तुम्हें ये मालूम है क्योंकि आप सब यंग जनरेशन के लोग हो। व्हाट अबाउट दिस पीडीएफ? यार ये पीडीएफ की कहानी, मुझे तो कोई दिक्कत नहीं, मगर कुछ लीगल कॉम्प्लिकेशंस होते हैं तो हम पीडीएफ नहीं दे पाते। तो अब ये प्रेपलैडर से बात करिए, मुझे तो कोई एतराज़ नहीं है, पर क्योंकि मैं प्रेपलैडर के लिए काम करता हूँ तो प्रेपलैडर वालों का एतराज़ है, तो फिर मैं उनके दायरे के बाहर तो नहीं जा सकता ना। पर ये वीडियो आपके पास हमेशा रहेगा, तो यहीं से स्क्रीनशॉट ले लो, पीडीएफ बन गया। पीडीएफ बनाने में क्या, स्क्रीनशॉट ले लो बीच में थोड़ा बहुत मजाक ज़रूरी है, क्यों पता चला कि बच्चे सारे सो गए, मैं पढ़ा रहा हूँ बच्चे सो रहे तो बीच में थोड़ा सा मजाक ठीक है। लिटिल बिट ऑफ ह्यूमर इन लाइफ इज़ गुड, अदरवाइज़ मेरे जैसा आदमी बहुत सीरियस आदमी है, मेरे साथ रहोगे तो और सीरियस हो जाओगे, फिर बोलोगे कि लाइफ में तो ट्रेजेडी क्या हो रहा है। मगर लाइफ में ऐसा नहीं है कि ट्रेजेडी है, कभी कभी ट्रेजेडी है। लाइफ वैसे कॉमेडी है, मोस्ट ऑफ लाइफ इज़ कॉमेडी, लिटिल बिट ऑफ ट्रेजेडी, थोड़ा सा रोमांस है। अगर सामने वाला हाजिर हो और इकरार कर रहा हो हाजिर है और इकरार नहीं कर रहा तो भी रोमांस नहीं हो सकता। वन साइडेड रोमांस करोगे तो लोग बोले साइकोपैथ है। दैट इज कॉमेडी। तो लाइफ 90% ऑफ लाइफ इज कॉमेडी, 9% is tragedy, 1% is romance. Tell me, what are these structures? See, first of all, it is a transverse section of the brain, and then you can see ये जो white color दिख रहा है ये CSF है. So lateral ventricles sending CSF into third ventricle, which is the midline ventricle. So these are lateral ventricles filled with CSF, sending CSF into third ventricle, and third ventricle is a midline ventricle sandwiched by two thalami. So marker B is thalamus. Marker B is thalamus because it is the thalamus which will be sandwiching the third ventricle in the midline. Diencephalon, thalamus, third ventricle. So third ventricle is the ventricle of diencephalon, and it is the ventricle of thalamus. Now, related to lateral ventricles, this marker which you see here is caudate nucleus. Mostly in this section it will be head of caudate nucleus. So head of caudate nucleus, which I will draw here. Then you can see, I will change the color, lens shaped lentiform nucleus, lens shaped lentiform nucleus, part of basal ganglia. Lentiform nucleus and caudate is part of basal ganglia, and then this is claustrum. Marker A is called as claustrum. Let me write here claustrum, C-L-A-U-S-T, claustrum, claustrum. So just wanted to know the details. Maybe they are not very much evident, but when you draw a schematic diagram, it will become evident. So let me draw it myself. Say this is the midline of the body, this is anterior, that is posterior, same diagram, anterior, posterior, midline of the body, and these are the two thalami. These are the two thalami sandwiching the third ventricle in the midline, sandwiching third ventricle in the midline. This is the third ventricle in the midline, and then you can also show lentiform nucleus lentiform nucleus laterally, lentiform. If you want to use the same color, let us use the same color. Lentiform laterally, sorry, little bit of running nose. And then what about the caudate? If you want to see the caudate, head of caudate. Now the point is, this much is evident to you. A claustrum, if you want to see, the claustrum will be here. This is claustrum. C, claustrum. Marker A is claustrum. Internal capsule. So examiner has asked you a question on internal capsule, and we wanted to know about the internal capsule in this diagram. Internal capsule is arranged in a V-shaped fashion, sandwiched here. Internal capsule is basically collection of axons, so it will be sandwiched here like this. Not only this side, but also that side. And lentiform is always lateral to internal capsule. Lentiform is always lateral to internal capsule. As you can see, this is the internal capsule, and lentiform is always lateral to internal capsule. Now, internal capsule will have anterior limb, a bent genu, and posterior limb. Anterior limb, a bent genu, and posterior limb. And you can notice, anterior limb of internal capsule is sandwiched between lentiform laterally, caudate medially, whereas posterior limb of internal capsule is sandwiched between lentiform laterally and thalamus medially. Thalamus medial, lentiform lateral. Posterior limb of internal capsule, bend is genu. Human body is represented in such way that you can show here. Let us use some color which is not yet used here. Yellow. So that will be the head, not evident. So let us darken it. Head portion in the genu. This is trunk portion, upper limb, lower limb. The point is, if there is a lesion in the genu of internal capsule, sensory motor problem on the face. If there is a problem in the posterior limb of internal capsule, sensory motor problem on the upper limb, trunk, and lower limb. And different parts of internal capsule has different artery supply. So if artery to the genu is compromised, sensory motor problem on face. If artery to this part of internal capsule compromised, then problem of upper limb, sensory motor problem. If artery to this part of internal capsule is compromised, then lower limb will be affected. And in the posterior part of internal capsule, you also have to mention sublentiform fibers and retrolentiform fibers. Now, when you say sublentiform fibers, they are passing under lentiform for hearing pathway, and retrolentiform means they are passing retro behind lentiform for visual pathway. So sublentiform, under lentiform, they go under lentiform, auditory pathway, and retrolentiform means they are behind the lentiform. That is why retrolentiform, and they will be for visual pathway. They have different arteries. If those arteries compromise, problem of hearing and problem of vision. They also belong to posterior part of internal capsule. So posterior part of internal capsule is more important than anterior part of internal capsule, because most of the functions belong to posterior part of internal capsule. Now, that is one thing. Second thing is, how do you identify? See, this is also one question which is easy now for you, because once you are through the discussion, it becomes easy. So lentiform they are showing here. This is lentiform. This is caudate. This is caudate. This is thalamus. This is thalamus. If you want to zoom, do that. So they were talking about lentiform. Where is internal capsule? If you want to locate the internal capsule, anterior limb, the anterior limb of internal capsule, sandwich between lentiform lateral, caudate medial. This is the genu. This is the posterior limb of internal capsule. Posterior limb of internal capsule sandwich between thalamus medially. Lentiform is always lateral to internal capsule. And remember, internal capsule is a projection fiber projecting from upper brain center to lower brain center and vice versa. So internal capsule is basically a projection fiber and projecting from upper brain center to lower brain center and vice versa. Collection of axons. Okay. This is the question. So repetitively they will ask you same thing. You have to be careful where the pointer is. So where the pointer is. This time pointer is anterior limb of internal capsule. This is the bend, this is posterior limb. Pointer can be on lentiform, pointer can be on internal capsule, pointer can be on caudate, pointer can be on thalamus. So this time the pointer is on internal capsule. A is the answer. And what was the answer in the previous question? In the previous question you already know pointer is on lentiform. So this was the answer, lentiform. That is why we tell that keep practicing previous year questions, and you have books also, but these days better than books you can just follow the YouTube discussions. Only problem with YouTube discussion is somebody mentioned some name of the faculty. I do not want to unnecessarily comment upon things, but always follow some faculty who is genuine in content. Content who is specialized in content means if you are just talking about anatomy, he should be MD anatomy at least. And I should not say much because, but you should be careful who is your teacher. These are some of the details which you already have seen. It will be just a repetition, but you can see for yourself. Anterior limb, genu, posterior limb. That is how it will appear in a cadaver section. Cadaver section. This is the third ventricle in the midline. Zoom it. Third ventricle in the midline. Thalamus on either side. Lentiform laterally. Claustrum. Gray matter. Claustrum is gray matter. Lentiform is gray matter. In lentiform also outer putamen, inner globus pallidus. Outer putamen, inner globus pallidus. Okay. Can you see the midbrain here? You see superior colliculus of midbrain, cerebellum posteriorly. Then what is this here filled with CSF? What is this here filled with CSF? Fourth ventricle. Fourth ventricle, which is having a roof of cerebellum, but it does not relate with midbrain. Be careful. It will be related with the pons and lower medulla. So, okay, I think that should suffice our requirements here. Let me see what is the time at this moment. 7, 5 to 7. Okay. So, we wanted to, I do not know, it is a difficult task to finish off topics within this limited time. Previous year questions का आंसर कौन से वाले questions का? ये पीछे रह गए उनकी बात कर रहे हो? दे दिया ना आंसर. ये देखो इसका आंसर क्या है? ये इंटरनल कैप्सूल है, इसका आंसर लेंटिफॉर्म है, और इसका आंसर आप खुद ही बना लो, ये थोड़ा लंबा हो जाएगा, पर अगर आप बनाना ही चाहते हो तो बना लो। डी जो है लेंटिफॉर्म है, डी को देखो लेंटिफॉर्म कहाँ लिखा हुआ है, ये लिखा हुआ है, डी लेंटिफॉर्म है, बाकी डी में कहीं लेंटिफॉर्म है नहीं, तो आंसर यही होगा, डी लेंटिफॉर्म है, सी कॉर्डेट है, सी कॉर्डेट है, तो आंसर 4 हो गया। ये है आपका आंसर यहाँ पर। बाकी मैं आपको एडवाइस यही करूँगा कि देखो, अगर आप ये कहो कि 2 घंटे में ही सर सारा पढ़ा दो, वो आप भी जानते हैं कि पॉसिबल नहीं है, और पढ़ाने को पढ़ा भी सकते हैं, लेकिन वो फॉर्मेलिटी हो जाएगी कि आए, कुछ बोला और चले गए, और फॉर्मेलिटी मेरी ज़िंदगी में कभी भी प्रायोरिटी नहीं रही, मतलब मैं फॉर्मेलिटी नहीं करता। सर आई एम फाइनल मेडिकल स्टूडेंट, हाउ शुड आई अप्रोच इन द दिसंबर FMGE? मैं देखो, एक ही अप्रोच है, प्रैक्टिस एज मैनी MCQs एज पॉसिबल, watch some good faculty discussing the MCQs and revise it again and again. That is the best way. Okay? तो भाई आज ये क्या थोड़ा लैग चल रहा है क्या? आप लोअर मेडला कहाँ पहुँच गए? हाउ लॉन्ग इज दिस वीडियो? देखो, क्वेश्चन पूछ लिया और पसीना भी निकल रहा है, तुम्हारा पसीना भी, हमारा पसीना भी, पता नहीं AC 18 पे चल रहा है, दरवाजा भी बंद है, छोटा सा कमरा है, डाइकिन का AC पसीना ऐसे निकल रहा है जैसे पता नहीं क्या तुम्हारा भी पसीना निकल रहा है, तुम कहाँ AC में नहीं बैठे क्या? सर हाउ लॉन्ग इज दिस वीडियो गोइंग टू रन सो आई कुड हैव अ लिटिल चेंज इन माई शेड्यूल? नो चेंज, नो चेंज। देखो भाई, हमने हो गया, अच्छा, तो भाई हम तो 7 बजे कहा था, 7 बजे हम बंद कर देंगे, कल फिर मिलेंगे। सो टुमारो द शेड्यूल विल कंटिन्यू, एनाटॉमी 1 वाज टुडे, एनाटॉमी 2 विल बी टुमारो स्टार्टिंग 5 till 7। आपका ज़्यादा समय नहीं लूँगा, तो कल मिलते हैं फिर, है ना? रूफ पे बैठा हूँ, अच्छा, अरे गर्मी में रूफ पे कैसे बैठे हो भाई? अच्छा, फर्स्ट OT में पूरा हिंदुस्तानी है, हमें तो आदत होती है, कोई फ़र्क नहीं पड़ता, गर्मी सर्दी से क्या फ़र्क पड़ता है मुझे तो। अभी तो खैर ज़माना बदल गया है। चलो भाई, आपका ज़्यादा समय नहीं लेंगे, इस वक्त आपका समय आपके साथ ही गुजरना चाहिए। सेल्फ स्टडी इज़ द मोस्ट important thing which you can do. We can just guide you, put you on track. We can tell you that how to approach the things, but eventually you have to work smart and hard. And it's very simple thing, you know, just practice previous year questions and keep practicing. So it's smart work, and hard work is continue doing that. And definitely you will become a very good doctor. Sincere belief, trust, faith. हमें देखकर अगर आप अच्छे डॉक्टर नहीं बन पाए तो हमें ही शर्म आएगी। अच्छे डॉक्टर बनो। टेक केयर।